It is the most common clinical condition, acute appendicitis. It is most common surgical emergency. So, if we talk about the anatomy of the appendix, what actually appendix is? So, appendix is a narrow tube, or we can say diverticulum, which is attached to cecum. Cecum is the first part of large intestine. So the appendix is the narrow tube, or we can say diverticulum, which is attached to the cecum. Cecum is the first part of the large intestine. What is the diameter of appendix? So appendix is a very narrow tube. Like if this is the cecum and it is attached to the base of the cecum, this diverticulum, we call this appendix. This diameter, this lumen of appendix is 5 millimeter. Length of appendix. So the average length of appendix ranges from 5 to 15 centimeter. This length of the appendix is 5 to 15 centimeter. Now, where is appendix located? So we draw an imaginary line in the abdomen to divide the abdomen into 9 quadrants. This is midclavicular line, this is hypochondrial line, and this is, so these lines divide the abdomen into 9 quadrants. This quadrant we call left upper quadrant, this we call right upper quadrant, this we call epigastrium, this we call hypogastrium. This is umbilical quadrant. This is called left lumbar quadrant, this is called right lumbar quadrant, this is called left lower quadrant, or we call left iliac fossa, this we call right lower quadrant or right iliac fossa. Here we have a bone like this. This bone is called iliac bone, which is the pelvic bone. So there is a very large fossa in the iliac bone. This fossa we call iliac fossa. So on both sides we have iliac fossa. So the fossa on left we call left iliac fossa, and on right we call right iliac fossa. So actually this appendix is situated or located here in the right iliac fossa. How? Let's draw the diagram of GIT. So we have esophagus, then we have stomach, then small intestine, duodenum, jejunum, ileum. At the terminal part of the ileum, here is a valve. This valve is called ileocecal valve. Here starts the large intestine. The first part is called cecum. Then we have different parts of the large intestine. Here we have the sigmoid and rectum anal canal. So if divide the abdomen, so it becomes like this. So appendix is located in the right lower quadrant, or also we call right iliac fossa. So this is the location of appendix. Now we talk about the blood supply of the appendix. Blood supply. Which artery supply the appendix? So the artery which supply the appendix we call appendicular artery. This appendicular artery arises from ileocolic artery. And this ileocolic artery arises from superior mesenteric artery. And this superior mesenteric artery arises from abdominal aorta. And this abdominal aorta is a continuation of arch of aorta. So let's see, we have like this. This is the abdominal aorta. Here it gives a branch which we call superior mesenteric artery. This superior mesenteric artery gives many branches. Important branch is middle colic artery, then it gives right colic artery, and then it gives ileocolic artery. Here we have intestines like cecum, ascending colon, transverse colon, and this side descending colon. So this middle artery supplies this transverse colon, and these arteries form anastomosis like this, which we call arcades of arteries, like this. So this artery we call ileocolic artery. Ileo means ileum, colic means colon. So this supplies the ileum and the colon. Here we had ileocecal wall, and here was ileum. So this artery actually supplies the ileum, terminal portion of the ileum, and colon, cecum. Here it gives a branch. This branch is called appendicular artery. Here we had appendix attached here at the base of the cecum. This artery travel in the mesentery of appendix and enter the vermiform appendix. This artery we call appendicular artery, which is a branch of the ileocolic artery. Ileocolic artery is a branch of superior mesenteric artery. Superior mesenteric artery is a branch of abdominal aorta, and abdominal aorta is a branch of arch of aorta. Like it's not a branch, but the continuation of arch of aorta. So this was the blood supply of appendix. Now which veins? So the veins, like veins which carry deoxygenated blood from the appendix is appendicular vein, which then joins posterior cecal vein. So this is the cecum, and on the posterior surface we have cecal vein. So this appendicular vein then joins posterior cecal vein. So this is the venous return. So lymph nodes, from where, like the lymph nodes where goes from the appendix. So where we have like this is the ileocolic artery, and here we have lymph nodes around the ileocolic artery. We call it ileocecal lymph nodes. So the lymphatic supplies return to the ileocecal lymph nodes. So these are the lymphatic nodes which drains the appendix. So this was the basic anatomy of the appendix. This item. So in etiology, anything which can obstruct the lumen, anything which can obstruct the lumen will initiate appendicitis. So the obstruction of the lumen is very important in the initiation of the inflammatory condition. So basically, we have like different things which can obstruct the lumen. Number one, piccolith. Piccolith is like feces combined with the cellular debris, mucus, feces plus cellular debris plus mucus plus bacteria. We call piccolith. So it can obstruct, it can enter the lumen and obstruct the lumen. It is the most common cause of obstruction in old age. Number two, piccolith we have the most common in old age. Then we have lymphoid hyperplasia. In the appendix, we have four layers: mucosa, then submucosa, then muscularis externi, and then serosa. All the four layers of GIT are present in the appendix as well. Number one, mucosa. Number two, submucosa. Then muscularis and serosa. So these four layers are present. So in the submucosal layer, we have aggregation of lymphoid tissue. Aggregates of lymphoid tissues are present in the submucosal layer. So whenever there is an infection in the intestine, like if there is viral infection in the children or due to any infectious cause, this lymphoid tissue proliferate and it causes lymphoid hyperplasia, increased number of lymphoid tissue. This can actually obstruct the lumen. So this is the most common cause of obstruction in children. The most common cause of obstruction in old age was piccolith. The most common cause of obstruction in children is the lymphoid hyperplasia. Then we have stones. Any types of stones can obstruct the lumen. Then we have parasites. Parasites can enter the lumen and obstruct the lumen. And the parasite we have, the most common parasite which can obstruct is the pinworm, especially Oxyuris vermicularis. This is a pinworm which can enter the lumen and obstruct the lumen and causing obstruction and that lead to appendicitis. Then we have carcinoma of cecum and tumors of appendix itself, which is adenocarcinoma of appendix or carcinoid tumor. So these are the most common causes of obstruction which can lead to appendicitis. Now we will talk about the pathology or pathogenesis of appendicitis. So as we know that obstruction is necessary for appendicitis. Initially, in early stages, of inflammation which is related to lymphoid hyperplasia, when the inflammation is started by the lymphoid hyperplasia in the early stages, there may be no obstruction in lumen. The inflammation only present in the mucosa and submucosal layer of appendix. So in that infection in which the cause is lymphoid hyperplasia, so in the early stages of that infection, there may be no obstruction in the lumen in the initial stages, and the infection is only restricted to the mucosa and submucosal layer in the early stages. Now, if further lymphoid proliferation occurs, if further the lymphoid tissue proliferate and hyperplasia occurs, then it leads to obstruction of lumen. When this obstruction of lumen occurs, then we have following conditions can arise. Number one, first of all, it blocks lymphatic outflow. When the lymphatic channels are blocked due to obstruction of the lumen, so the first thing developed is edema. This edema, which is due to the blocked lymphatics, and the blocked lymphatics is due to the obstruction of the lumen. Let's see here, this is the appendix. Here is the obstruction due to hyperplasia. In this obstruction occurs, the pressure inside the lumen is increased. When this pressure inside the lumen increased, it obstructs the lymphatics in the wall of the appendix. When this lymphatics obstruct, so here we have edema in the wall of appendix. So edema in the wall of appendix develops due to obstruction of the lumen. When this edema develops, so the further it will lead to venous obstruction. Due to progressively increasing pressure inside, it will now lead to the venous obstruction. If the venous obstruction occurs, the wall of the appendix becomes ischemic. Ischemia develops in the wall of the appendix. This ischemia leads to necrosis, and after necrosis, we have gangrene formation. So these are the stages of pathogenesis in the appendicitis. First of all, there will be obstruction. This obstruction will lead to increased intraluminal pressure. This increased intraluminal pressure will cut off the lymphatics. When lymphatics cut off, the lumen pressure further increase, and this lumen pressure further increase, it will obstruct the veins. So when venous obstruction occurs, there will be ischemia of the wall of the appendix, and this ischemia will lead to necrosis, and after necrosis, there will be gangrene formation in the wall of the appendix, which we call gangrenous appendicitis. Now, there is continuous proliferation inside this lumen. We have continuous proliferation of bacteria, which is mixed type of bacteria which contain both aerobic and anaerobic. So at the same time, bacterial proliferation also starts an increase in the lumen. This gangrene formation, this ischemia, and after gangrene we have perforation. So these three things can lead to peritonitis. Like when there is ischemia, this bacteria can travel through the ischemic wall to the peritoneal cavity and causes peritonitis. This bacteria can travel to the gangrene through the peritoneal cavity and causes peritonitis. If there is a rupture of the appendicular wall, so this bacteria can travel to that perforation into the into the peritoneal cavity and causing peritonitis. So these three are the ways by which peritonitis is resulted in the acute appendicitis. Now, if we have mucosal and submucosal inflammation, only inflammation is restricted to mucosa and submucosa, and if we give antibiotics in this case, it can resolve, or it can also spontaneously resolve. So, at the early stage of appendicitis, in which there is mucosal or submucosal inflammation, by giving antibiotics, or spontaneous resolution can occur. But if it progresses from this stage, then it will lead to lymphatic obstruction, then venous obstruction, ischemia, necrosis, gangrene formation, and finally perforation. So next, we have clinical features or symptoms of appendicitis. So we have the following symptoms. Number 1, pain. Pain typically starts in periumbilical area around the umbilicus, periumbilical area. Then it radiates to right iliac fossa, and then it stays in right iliac fossa. So these are the pain characteristics. Starts in the umbilicus area, then radiates to right iliac fossa, and then stay in the right iliac fossa. Number 2, vomiting. Usually 1 or 2 episodes of vomiting occurs in the acute appendicitis. We have nausea. 4, we have anorexia. And this anorexia is most common in children. Pain on cuffing. When the patient tries to cuff, so it feels pain in the right iliac fossa. So these are the main symptoms of acute appendicitis in a typical case. In atypical case, when the presentation is atypical, not more common, so we have like pain arising and staying in the right iliac fossa, like there is no first periumbilical pain and then migrating to the right iliac quadrant. Pain originates in the right iliac fossa and stays there. This is atypical scenario. And then we have the second thing in atypical is like diarrhea. Usually in typical presentation we don't have diarrhea, but in atypical presentation we have diarrhea. In atypical presentation we also have urine frequency, like increased amount of urine. This condition occurs if the inflamed appendix is touching the urinary bladder. So we have increased frequency of urine. So these are the typical and atypical presentation symptoms of the acute. Signs of appendicitis. So on physical examination, which signs we can appreciate in the patient with acute appendicitis? So number 1, we will have look for temperature. There will be slight pyrexia. Slight pyrexia means slight elevation in temperature. It will not cross from 37.2 to 37.7 degrees Celsius. This is the slight pyrexia. If it is more than 38.5 degrees Celsius, usually, and with the pain in the right iliac quadrant and nausea, vomiting, and having temperature more than 38.5 degrees Celsius, it usually indicates mesenteric adenitis. The first thing we will look for temperature. Second, we will look for pulse. Pulse rate is usually slightly increased due to increase in temperature and increase in fever. We have slight increase in pulse. Then we will look for like mouth. In 50% of patients, there is a condition which we call pitor oris. Simple word we can call it halitosis. Bad breath from mouth. So in 50% cases, by mouth examination, we can appreciate pitor oris, which is nothing just halitosis, and we can also check for tonsils. Because if there is tonsillitis, so this tonsillitis is mainly associated with mesenteric adenitis. So it can give us a differential clue between mesenteric adenitis and acute appendicitis. The next step we can do is to look for respiratory movement in the abdomen. There will be decreased respiratory movement in abdomen. When we want to inspire the ear, it usually put the abdominal organ deep into the abdominal cavity. So this patient is having abdominal tenderness. So when this patient want to inspire, so he will not able to inspire completely, or he will not use his abdomen for inspiration. There will be completely diaphragmatic, there will be completely thoracic inspiration, and due to pain, there will be decrease in respiratory movements in the abdominal cavity. Next, we will check for rebound tenderness. For rebound tenderness, what we will do, we will join the line, an imaginary line we will draw between the umbilicus. For example, this is umbilicus and this is pelvic bone. Here we have anterior superior iliac spine. Anterior superior iliac spine. This is a bone prominence present on the iliac bone. We will join this line. Then we will divide this line into three parts. So at this point, it is 1/3 towards anterior iliac spine or 2/3 towards umbilicus. Here, this point we call McBurney point. And if we press on this McBurney point and we release our hand, so there will be tenderness, which we call rebound tenderness. On pressing the McBurney point, there will be no tenderness, but on releasing our hand, there will be tenderness, which we call McBurney tenderness, McBurney rebound tenderness. So the next we will have McBurney rebound tenderness. Then we will look for some signs, other signs, like the most important sign we will have pointing sign. What is pointing sign? In pointing sign, we will ask the patient about the pain character. So the patient will tell that the pain arises in the periumbilical area and it radiates the right iliac fossa. So this will be the pointing from periumbilical to the right iliac fossa. This is called pointing sign. Next, we will have Swoosh sign. So we have a muscle which we call Swoosh muscle. Like this is Swoosh muscle, and in front of Swoosh muscle we have this inflamed appendix. So what is Swoosh sign? In Swoosh sign, the inflamed appendix lies on Swoosh muscle, which will cause spasm of Swoosh muscle, and the patient will lie with the right hip flexed. So, for example, if this is right hip, this is knee, this is foot. So patient will try to flex this right hip. Like if this is abdomen, this hip will be like this. By the flexion of the right hip, these two structures separate from each other and there is no pain. So to prevent from pain, the patient usually occupies this position in which there is hip flexion, mainly right hip flexion. So if the patient is not in this condition, what we will do? We will extend right hip. When we extend right hip, this appendix will touch the Swoosh muscle and there will be pain and tenderness. This we call Swoosh sign. Next sign we have obturator sign. This is our right iliac crest. In this right iliac crest and this right iliac fossa, we have here a muscle. This muscle we call obturator internus. And here in the right iliac fossa, we have also appendix. And this appendix is inflamed. So when hip is flexed, when the right hip is flexed, and then we ask the patient to internally rotate the right hip. This movement causes pain in the hypogastrium. This pain in the hypogastrium by internal rotation when the right hip is flexed, we call obturator sign. So this is another sign of which is related to the acute appendicitis. Then we have Rosing sign. We have this is our right iliac fossa or right lower quadrant. This is our left iliac fossa and left lower quadrant. If we deeply palpate, we do deep palpation here in the right iliac fossa, left iliac fossa or left lower quadrant. The patient will feel the pain in the right iliac fossa or right left quadrant. Palpation in the left side will feel the pain on the right side. This sign we call Rosing sign. We have another sign which we call Penhorn sign. Pull the right testicle, it will cause pain. So this is called Penhorn sign. On coughing or laughing, the patient feels pain. This sign we call Trumpy sign. So in a nutshell, how many signs we have learned which are diagnostics of the appendicitis? Number 1, pointing sign. The patient will point the pain from umbilical area to right lower quadrant. We call pointing sign. Then we learn Swoosh sign. Extension of the right hip will cause pain. This is called Swoosh sign. Then we learn Rosing sign. Deep palpation in the left side, left lower quadrant will cause pain in the right side. Then we learn Penhorn sign. If we pull the right testicle in lower direction, it will cause pain. We call Penhorn sign. Then we learn obturator sign. If we flex the right hip and then internally rotate the right hip, it will cause pain in the hypogastrium, which we call obturator sign. Then we learn Kempis sign. If the patient wants to cough or laugh, it will cause pain in the right iliac fossa. This sign we call Kempis sign. So these are the signs related to the acute appendicitis. Now, different forms of appendix, like where the appendix is located. So this we have cecum, and here we have ileus. So mainly in 74% of the cases, this appendix is situated on the back of the cecum. This dotted line represents the back of the cecum, not in the front, on the back. And this we call retrocecal appendix. It is the most common. We also have this appendix located on the back of the ileum like this. We call post-ileal appendix, which is less than 1%. This appendix can be situated in front of the ileus. We call pre-ileus. It is 1%. This appendix can be attached like this along the lower margin of the cecum. This we call coracecal. This is 2% or less. And this appendix can also be situated like this under the cecum. We call subcecal. And this appendix can also be pointing towards the pelvic cavity, which we call pelvic appendix, which is 21%. So the most common appendix shape is like this, retrocecal, and the second most common is pelvic, which is 21%. Now we talk about appendicitis in pregnancy. So appendicitis in pregnancy is the most common non-obstetric surgical disease of abdomen. So non-obstetric means it's not related to pregnancy. Non-obstetric surgical disease of the abdomen, which the most common is appendicitis. We have the typical right iliac fossa pain. We have like vomiting. We have like anorexia. All things will be same as that of the normal typical presentation. But one change is here that the location of the appendix change according to the gestational age. So mainly we have this anterior superior iliac spine, this is umbilicus, and this is McBurney spine, and appendix is located here. But as the uterus is growing, the cecum and the intestines are pushed forward. So at the 3 month of age, it may be located here, 4 month may be located here, 5, 6. At the 8 to 7 month, it is located just above the right lower ribs. So according to the size of the gestational age, the location of the appendix change because the uterus pushed the intestines upward. So when the intestines are pushed upward, the location of the appendix change. The investigation of choice we can do is MRI, which we usually do in second or third trimester. We can also do in second and third trimester CT scan, but not in first trimester. And we do appendectomy usually in second trimester. So these are some points related to appendicitis in pregnancy. Now we will discuss about the differential diagnosis of appendicitis. So we divide it into children, adults, and females. So in children, number one differential diagnosis is gastroenteritis. How we will differentiate here in gastroenteritis? We have diarrhea, which usually not in appendix, and there will be no right inferior fossa pain, and diarrhea and vomiting are prominent. Second is mesenteric lymphadenitis, inflammation of the mesenteric lymph nodes. In this case, we have fever greater than 38.5 degrees Celsius, which is never in appendicitis. In appendicitis, it is slightly pyrexia, 37.2 to 37.7. It never crossed 38.5. And here, it is mainly associated with tonsillar inflammation. There will be cervical lymphadenopathy due to tonsillar inflammation. Cervical lymph nodes will be swelling. There will be circumoral pallor. What is circumoral pallor? Like this is mouth of the child, and around this mouth we have a pale color, which we call circumoral pallor. So this circumoral pallor is usually not present in appendicitis. The most important differential diagnosis between the mesenteric lymphadenitis and acute appendicitis is shifting of tenderness. This is most valuable point in mesenteric lymphadenitis. What is shifting of tenderness? In acute appendicitis, the tenderness located here in the right lower quadrant. But in mesenteric adenitis, we will locate the point of tenderness, and then ask the patient to lay down on left lateral position. When the patient lay down on left lateral position, like here was the point of tenderness in abdomen. Now when the patient lift on this side, so this mesentery, due to gravity, it will go down. So the point of maximum tenderness will shift from here to here due to the gravity, which shifts the mesenteric lymph nodes from one point to another. We call this shifting of tenderness. This shifting of tenderness is not present in acute appendicitis. It is present in mesenteric lymphadenitis. Then we have other differential. We have diverticulitis. In diverticulitis, there is mainly central pain, and in rare cases, we also have bleeding, which is not present in appendicitis. Then we have a condition which we call Heno-Schönlein purpura. Heno-Schönlein purpura. In Heno-Schönlein purpura, we have abdominal pain, but this abdominal pain is post-infection. Like there will be history of infection in the tonsils, there will be pharyngitis, plus there will be rashes on extensor side of legs. So these are the differential diagnosis of Heno-Schönlein purpura with the acute appendicitis. Next we have intussusception. What is intussusception? Like we have this cecum and this is ileum, here we have a wall. When this ileum goes inside into the cecum, we call this condition intussusception. This also will be pain in the right lower quadrant, but here the main point is red current jelly stools. The stool will be red current jelly stools in appearance. So this is the differential diagnosis of intussusception with acute appendicitis. Sometimes we have lobar pneumonia. In lobar pneumonia, the pain is a referred pain which is shift due to the lower intercostal nerve into the abdomen. So in this case, we will check X-ray and we will rule out the pneumonia for a differential diagnosis with the acute appendicitis. Now we will talk about differential diagnosis of acute appendicitis in adults. So first we have acute pancreatitis. In acute pancreatitis, we have abdominal pain, but this abdominal pain radiates backward. Number 1 point radiates backward. Plus, in acute appendicitis, the amylase, which is pancreatic enzyme, and lipase level increase, but this increase is more than 4 times. In every abdominal condition, the amylase and lipase level increase, but in acute pancreatitis, this level increase more than 4-fold. So when we have these things like increase in 4-fold and radiate backward pain, so we can rule out acute appendicitis and we can go towards acute pancreatitis. The second condition we have acute cholecystitis. So the pain is in the right upper quadrant, and on abdominal ultrasound we can rule out acute cholecystitis. Then we have ureteric colic. What is ureteric colic? If there is pain which is due to the obstruction by stone in the ureter, we call ureteric colic, a colicky pain. So what we will do X-ray KUB. KUB means kidney, ureter and bladder. So we will take view of kidney, ureter, bladder, X-ray, KUB, and we will rule out the ureteric colic. Then we have pyelonephritis. So acute pyelonephritis, the pain is usually in the loins, in the plank areas. Thus there is fever, thus there is pus in the urine, which we call pyuria. So this will rule out the pyelonephritis. Then we have perforated peptic ulcer. In perforated peptic ulcer, pain in the epigastrium, it may radiate backward Plus, when we do erect posture X-ray, there will be gas under diaphragm. So this will rule out the perforated peptic ulcer. Next we have testicular torsion. For testicular torsion, we also feel pain in the right inferior fossa. So for testicular torsion ruling out, we will do scrotal examination. And the last, which is very rare condition, we have rectus sheath hematoma. In rectus sheath hematoma, we also have abdominal pain. But this pain is usually after trauma or exercise. So these are the differential diagnosis between acute appendicitis with elderly age patient. So differential diagnosis of acute appendicitis in females. So first we will differentially diagnose this with pelvic inflammatory disease. If there is inflammation in the pelvic organ, we call it pelvic inflammatory disease. In this situation, the pain is bilateral on both sides of the abdomen. Pain is bilateral on both sides of lower abdomen. There is cervical tenderness on examination. There may be vaginal bleeding or vaginal discharge. Second condition in female which is have differential diagnosis with acute appendicitis is metal schmerz. Metal means middle, schmerz means pain. At the time of ovulation, there is slightly moderate moderate severity. There is slight pain during at the time of ovulation. We call it metal schmerz pain. This pain is of moderate severity, like this is not that much severe. And the second thing is it goes away spontaneously. So this is metal schmerz pain. Next we have ectopic pregnancy. Any woman who is of reproductive age presents with acute abdominal pain, we will rule out pregnancy by ultrasound or beta HCG. Then we have torsion or cyst of ovaries. For this we will use like ultrasound and gynecological opinion. So these are the differential diagnosis in female with the acute appendicitis. Next we have differential diagnosis in elderly patient. Elderly. So in elderly patient, the most common is there is cancer of cecum. In the cancer of the cecum, there will be like mass in the right inferior fossa. There will be weight loss. There will be altered bowel habits. There may be signs of intestinal obstructions. So the first is cancer or carcinoma of the cecum. Then we have sigmoid diverticulitis. This is sigmoid, and if here a diverticulum form, we call sigmoid diverticulum. And if there is inflammation of this diverticulum, we call this sigmoid diverticulitis. And this is very difficult condition to diagnose with the normal clinical history and clinical method. For this, we will use CT scan as a diagnostic. Then we have intestinal obstruction. In intestinal obstruction, there will be vomiting, there is dehydration, there is severe pain. If small bowel is obstructed, it is central pain. If large bowel is obstructed, it is peripheral pain. It depends. For intestinal obstruction, we have a separate video. On the large bowel, we have like this fatty tissues which protruding out. This fatty tissue we call epiplochia. If there is the torsion of the epiplochia, it twists around itself, this can cause pain. And this pain we will diagnose on CT scan. So we have this condition we call torsion of epiplochia. This is fourth condition. Now we have mesenteric infarction. In mesenteric infarction, there is like embolus, thrombus, which blocks the mesenteric artery, and the colons or gut which are receiving blood supply from the mesenterium, from this mesenteric artery. There is ischemia, and after ischemia there is infarction, necrosis. So we call this mesenteric infarction. In this mesenteric infarction, the pain is very severe and proportionate to the findings on physical examination. Then we have aortic aneurysm. Abdominal aortic aneurysm, we call AAA. In abdominal aortic aneurysm, there will be pain in the abdomen, plus there will be signs and symptoms like shock. So these are the differential diagnoses in elderly. Next, we have diagnosis of acute appendicitis. How we will diagnose the acute appendicitis? So if we suspect the acute appendicitis, the first test we do is abdominal ultrasound. This is the first test done. If we have to suspect differential diagnosis, like if there may be suspicion between two causes, like if we say that this may be acute appendicitis or this may be intestinal obstruction, so in these cases we can do X-ray. If we do X-ray, we will rule out the intestinal obstruction, and we can also rule out if there is like air fluid levels, which is the main symptoms and the main signs seen during intestinal obstruction. By X-ray, we can also rule out ureteric colic if there is any stone in the ureter and causing the pain. We can also do pregnancy test to rule out pregnancy. For urine, we will check urine for urine analysis. We can rule out acute urinary tract infection. We will see complete blood count. In complete blood count, we will see leukocytosis. The leukocytes will be increased, and there will be increase in immature neutrophils, which we call shift towards the left. So we will see these two things in the CBC. Now, if we are suspecting and we cannot take positive result from the ultrasound or the X-ray, the next step we can do is CT scan. CT scan is the gold standard. CT scan never miss acute appendicitis. Gold standard of diagnosis is CT scan. So the first test done is ultrasound abdominal, and the gold standard for diagnosis of acute appendicitis is CT scan. Now we have a scoring system which we call Alvarado scoring system. Alvarado scoring system, we check some points and we give it score. Like the first thing we check is migratory pain. If there is migratory pain, the pain is migrating from the periumbilical area to the right inferior fossa. We will give it a score of 1. Then we will check anorexia. If there is a history of anorexia, we will give a score 1. If there is history of nausea or vomiting, we will give a score of 1. If there is tenderness in the right inferior fossa, here we will give score of 2. If we press on the McBurney point and on releasing there is tenderness, we call this rebound tenderness. For rebound tenderness, we will give a score of 1. If there is elevated temperature, we will give a score of 1. For leukocytosis, we will again use 2 score. And if there is shift of neutrophils to left, like more immature neutrophils are coming into the circulation, we call this shift to the left. So if they shift to the left, we will give a score of 1. So the total score is 1, 3, 4, 5, 7, 8, 9, 10. So the total score in Alvarado is 10. If less than 5, no appendicitis. If this is 5 to 6, it is equivocal. Equivocal means that it may or may not be appendicitis, and we will go to CT scan. We will go for CT scan to confirm the diagnosis. Then if it is greater than 7, it is confirmed. Equal to or greater than 7, it is confirmed case of acute appendicitis. We manage patients with acute appendicitis. So the only treatment available for acute appendicitis, we will remove the appendix, which we call appendectomy. So we have two methods of appendectomy. We can do it by open surgical method, or we can do laparoscopy. So in laparoscopic, we do a hole in the umbilicus, 10 millimeter hole, and we give gas inside the abdominal cavity. To with this process we call pneumatization. Pneumatization means giving air. So we achieve a pneumatization, and this the abdomen is like become like this. And with the different organs separates from each other, and whole abdominal cavity become filled with the gas, and the organs separate from each other. Then we do another incision 5 millimeter in the lumbar area and 5 millimeter in the suprapubic area, and we insert the instrument required for laparoscopic surgery, and we cut and cauterize the appendix and remove it through this process. We call this laparoscopic surgery. Then we have open surgical method. In open surgical method, the most common used incision is gridiron incision. So gridiron incision, we join the McBurney line. This is called an imaginary line run between the anterior superior iliac spine and the umbilicus. This line is McBurney. So perpendicular to this McBurney point, we give an incision perpendicular to this imaginary line. This incision is called gridiron incision. We separate the different layer of the abdomen, and then we enter into the peritoneal cavity. Another incision we can use is lens incision, and this incision is 2 centimeters below the umbilicus, but in the mid-clavicular line. Here it is the umbilicus 2 centimeters below. In the mid-clavicular line, we can give an incision, and this incision we call lens incision. In Rutherford Morris incision, this incision is used for oblique cutting of muscles. This is the McBurney point. So in Rutherford Morris incision, the lowest point of incision lies above the McBurney point, and it goes upward in oblique manner like this. This is called Rutherford Morris incision. If we are suspecting peritonitis. So in this case, we can give incision in the midline. Like if this is the abdomen, the umbilicus, we will give a midline incision or para midline incision. We call this lower midline incision in case of suspecting peritonitis. So these are the two methods of appendectomy. We have different scenarios coming out during appendectomy. So if the base of appendix is inflamed, do not crush. So if the base of the appendix is inflamed, we will not crush the appendix, we will just simply remove the appendix. In appendectomy, first like if this is appendix, we apply here artery forceps and we crush this area. Then we remove this artery forceps and we apply here. And then between this crushing point and this artery forceps, we cut the appendix and we take out the appendix. So we call this appendectomy. So the first step is crushing, but if the base of the appendix is inflamed, we will not crush. If second case, if there is Crohn's disease involving cecum, if there is Crohn's disease which involves the cecum, in that case we will not crushing the base of the appendix. So then we have the complications of the appendix. What are the complications of appendix? So number one complication, we will have appendicular mass. What is appendicular mass? When there is inflammation in any abdominal organ, say for example here is inflammation in the appendix. So the small intestine, the mesentery, the omentum, these all surround this inflammation to seal up this inflammation and prevent spread of this inflammation toward the abdominal cavity like the peritoneal cavity. And here a mass is formed. We call this mass appendicular mass. So in case of appendicular mass, it is very difficult to perform surgery and we follow a regime called Oshner-Sharin regime. In Oshner-Sharin regime, we give the patient nothing per oral. The patient is taking nothing per oral. We give Ryle's tube, which is nasogastric tube, for aspiration of the gastric content. We look for temperature. We look for size of the mass, appendicular mass. We give urine catheter to take out urine. So this is all, and we give triple regime antibiotics. Triple antibiotics. So this regime we call Oshner-Sharin regime, which we follow in appendicular mass. So if the size of the tumor is increasing, if there is temperature is increasing, in this case we will go for surgery. And if these are going down, size of the appendicular mass is going down and the temperature is going down, so we will go for interval appendectomy after 4 to 6 weeks. It means that the patient condition is improving. So we will wait and then after 6 to 8 weeks, 4 to 8 weeks, we will do interval appendectomy. The next complication we have in the acute appendicitis is abscess formation, appendicular abscess. Appendicular mass abscess. Next we have peritonitis. If this inflammation spread into the peritoneal cavity, we call peritonitis. Perforation. Fistula formation. Fecal fistula. If there is formation of abnormal opening between the two organs, we call fistula. Intraperitoneal abscess, sepsis, these are all the complications of acute appendicitis.